Welcome to podcast 2 for the cardiometabolic podcast series updates and expert perspectives in the management of chronic kidney disease in patients with type 2 diabetes. Today, we're going to be talking about counseling patients about CKD, a very important topic. We're going to focus on motivating patients who have CKD and type 2 diabetes, and we're also going to talk about care coordination for patients with kidney disease and diabetes. So, Kathy, let me start with you. What do you do to motivate your patient to do what they need to do? And there's a lot of things to help slow kidney disease progression in diabetes.
Well, hearkening back to our first podcast, I can't emphasize enough the importance of appropriate screening for both albuminuria and GFR to risk stratify patients. And then the KDIGO heat map is a very useful tool for patient education too, to show them where they are on the map and to explain what that means in terms of risks. But it's not just about ringing an alarm bell about the risks of cardiovascular complications, kidney failure, and death. It's also time to tell them there's a lot we can do about it. And this really is an unprecedented time in the field where we now have several, I would argue multiple classes now of highly effective therapies. And so if we can identify people early as possible, then we have the best opportunity for those therapies to maintain health. And I do think we need to give people hope and encouragement, and that we now have the tools in hand that will help keep people alive, keep their kidneys healthy, keep their hearts healthy. And I think that, most people who are seeking healthcare come to us because they want to be here and they want to live their lives and do the things that they're here to do. So I try to turn the alarm message into a message of hope, especially based on the new therapies that we have available to us.
So that's a very important question. In fact, since you mentioned that, what are these new therapies that are so miraculous?
Well, I guess, to be honest with you, it actually starts with an old class, ACE inhibitors and ARBs. In the first podcast, you heard from Dr. Agarwal that not only are we under screening, we're still underutilizing those therapies. And they're very effective for preservation of kidney function and for heart failure. But now we have the SGLT2 inhibitors, which have clearly been a breakthrough therapeutic class in terms of adding to additional protection from death, heart, and kidney events. We have finerenone, which is a non-steroidal mineralocorticoid antagonist that also benefits patients in the same ways. And there are emerging therapies under study, such as GLP-1 receptor agonists that clearly improve risk of atherosclerotic CVD. They're effective glucose-lowering agents, even in advanced CKD. And they're under study for kidney protection. But the early signals, especially on albuminuria reduction, are very promising.
So very good. Now, Rajiv, it takes a village. Famous words. And this is a complicated set of diseases. You have a metabolic disease with a consequence of microvascular disease and then kidney disease. So one person cannot possibly manage all this, not well. And the patient has limited resources. They need to get educated, and one person cannot do all this. So what is your approach in terms of coordinating the care, team approach, that kind of thing?
Great question, George. I think this is a disease, diabetes and chronic kidney disease, that is terribly difficult to treat if you don't connect with the patient. The reason is very simple. You're treating them and you're selling them an insurance policy. You're telling them if you take this therapy, you won't have bad things happen to them. But the bottom line is many of these therapies, as you start them, they will have some adverse effects. They might feel dizzy, lightheaded, have hyperkalemia, have genital mycotic infections, whatever. And the first thing that the patient does, or sometimes the primary care docs do, they'll stop the therapy. And the patient will just tell you, Doc, I'm not taking it. And I think it's really important to tell the patient why they're doing what they're doing, because if you don't tell them the why, how is immaterial. So my very first job is when I see the patient is I try to connect with them. I just give you an example. I have my clinic and I ask the patient, okay, this is a patient I saw, and he says, well, Doc, I live in Mexico half the year because, I'm a snowbird. I come to Indiana during the summer months. And then he tells me about his grandchildren and his children. And I said, look, you spend your time at the beach, right? And he says, well, I've got good news and bad news. The good news is you can be at the beach, but the bad news is you got diabetes and kidney disease. And would you like to get a treatment that will reduce your risk of coming in the hospital huffing and puffing and reduce the need for dialysis by about a third? He says, Doc, what is it? I'll take it. Now, what you have done is you have piqued his interest. You have actually motivated him to potentially take a treatment that he might persist with. I have patients who have had genital mycotic infections, and after the first one, they just don't want to take a drug because they said, Doc, I don't care what you tell me, I'm not going to take the drug. And there have been veterans, World War II veterans, who won't let the pharmacist stop the SGLT2 inhibitor after the third UTI because they would say, you need to talk to my kidney doc before you're going to do it. So I think that the way you connect with the patient is really important because remember, at the end of the day, you might be giving them a disease in the hope that you're selling them a prevention. And of course, you need all your colleagues to help you with this. One of my patients got in the hospital after starting SGLT2 inhibitor, and he had hypoglycemia. Instead of reducing his insulin, they stopped his SGLT2. And I said, hey, don't do that. He says, no, you started him on this drug. He got hypoglycemic. We're stopping your therapy. We need to educate people that this is not a drug that causes hypoglycemia. It's potentiating the effect of insulin. So I think we are getting there. It's a new class of drugs. And until we educate our colleagues and our patients and take them along with us, we won't be able to make a substantial dent in what we call diabetic kidney disease or, CKD associated with type 2 diabetes. That's the correct nomenclature now.
You're 100% right. These are critical points that need to be moved along all stages and reinforced in all stages when you see the patients. And again, one person cannot do this. So you do need a team. And this is why diabetes centers have teams of people that actually see this through. And there should be centers, if you want to modify them, that it should include cardiologists and nephrologists. And there are some centers that are developed that have this. So it is difficult, but it is doable if you have the right coordinated approach. I think that's the key. So I want to thank you both for joining me today. And we hope you got something out of this. And we hope that you stay tuned for the next podcast, which is going to focus more on the management of chronic kidney disease in patients with type 2 diabetes. So on behalf of Professor Agarwal and Professor Tuttle, this is George Bacris signing off on this one, and we'll see you on the other side.